Hello. So I'm thinking everyone's there. Rachel, can you just signify if...
Yes, I've let everyone in, Helen.
Lovely, perfect.
I'll just admit the others as they join.
Perfect.
Thank you.
Thank you. Thank you. So welcome everyone. I can't see you yet, and hopefully I can see you later. So I'm Helen Simpson. I'm one of the consultant endocrinologists at UCLH. A little bit of housekeeping before we start, because there's a lot of people signed up. I know not everyone will come. So can you keep your cameras and microphones off for the presentation? And at the end, please save all your questions to the end, and then turn your cameras on and I'll stop screen sharing. But keep muted unless you're asking a question. To ask a question, put your hands up. We all know now in the Teams chat. We'll do hands up and also questions in the chat. But I think it'll be a bit of crowd control. Well, we'll see how it goes. But do your hands up, and then we'll also keep looking at the chat. So remember everyone to keep muted, yeah? So this webinar today is hopefully all you need to know about the NICE guidelines for adrenal insufficiency. And this work came about because I am a member of the Royal College of Physicians Patient Safety Committee. I was working with the NHS England as advisor for Steroid Emergency Card, which I'm sure you're all using. And then I applied and was successful in getting the role of topic advisor. And if you can't see it, it should be, could somebody mute, please? And the guideline, I don't know if you can see it because my doodles are at the bottom, but I put the website at the bottom. So I think the first important thing to say is that there's a very clear process for a NICE guideline. It's probably not like, well, it definitely isn't like any other guideline I've been involved with. It's a real true evidence-based with health economic analysis. The topics are suggested by NHS England, and as I say, I applied to be topic advisor. There's a NICE team, so there's a central NICE team that has a big chair, and then there's a NICE lead for the committee, a NICE chair who is a rheumatologist, so a general physician, if you like, with using glucocorticoids, and then me as the expert, the subject matter expert. And then myself and the NICE lead, we then, an advert went out to be on the committee. So we appointed a committee, and I'll share the names of that because the committee was fantastic, and it involved adult and pediatric healthcare professionals, doctors, nurses, paramedics, pharmacists, and 3 lay people. The evidence gathering is the highest of any work I've been in that it's evidence-based on the Cochrane Handbook for Systematic Reviews of Interventions, a bit of a mouthful, but there's a really clear process. And I know when it came to going out to consultation, some people said, well, what about this? But it doesn't meet the threshold of evidence. And where there was other things where we were maybe using a review, or then the agreed to principles we use. There's a real clear methodology. As I mentioned, there's health economic analysis, and I went on a day course for this, which I would encourage everyone to think about. We're in a taxpayer system. If we offer something, then we have to stop doing something else. And that's where there has to be evidence for everything that's got a cost impact. And there's very strict declarations of interest. We had to be out of the room if there's a conflict of interest. So Simon Pearce and myself a couple of times had to be out of the room because of publications that we'd had. And every meeting, we had to declare any conflicts, any money we were being paid or anything like that. Sadly, I don't get money from anyone else, just the NHS, but that's fine. And sources of evidence, I will leave you to read this when the talk is shared later. And it's pretty wide ranging in terms of sources of evidence, but the literature, as I said, there's very strict rules about what can and cannot be used. And then obviously I had to explain to the NICE team, background teams, the team that were doing the searches. So although there was a NICE chair, there was a NICE lead, there was a whole team behind who were doing the searches, the health economic analysis. And so part of my role at the beginning was to talk about adrenal insufficiency, what it was. And so they got a small understanding of the clinical picture we were talking about. We had a lot of meetings, so there was quite a lot of meetings before the actual full committee meetings. We had about 12 committee meetings that were all day, and before that there's a pre-meeting. So there's a lot of preparation for each meeting, and really grateful for all the committee members. I don't know if anyone on the call today, because it's a lot of time, and as you know, there isn't money for this sort of thing. And then the draft went to the NICE editors when it was done. There's a lot of to and fro then, because it has to be nice language, it has to be specific, precise and concise. We put a lot of things that were too vague, and so there's a lot of work with the editors, even it goes out to consultation. Went out to consultation, came back with about 400 comments, and this was around Christmas, more junior doctor industrial action. So we then had to review and comment on all the comments, and then it goes back to the NICE editors before it can then be shared with the committee for the last general committee meeting. So you can see there's a lot of work. The language is really important, and there's a lot of process behind this. So if people feel their pet peeve wasn't in, there'll be a good reason for that, although I'm sure I've already found one mistake actually. I'm sure at the same time, the next version there will be improvements. And as I said, it's really important to acknowledge the people that did a lot of the hard work. I mean, it was a lot of work. And so again, you can read the names and it's on the NICE website. But you know, really, really grateful for the team who helped and were invaluable in getting this guideline done. So the contents, and I'm going to go through each of these sections, not in 100% detail, but hopefully pick up some of the major points. So, and sorry, just even when we got to the contents of the guideline, we had to devise the scope. So we had meetings to get the scope, and this is what came out from the scope. And then that had to go to consultation even before it was all agreed. So contents of the guidelines: information, support and decision making, initial identification and referral, routine pharmacological management, management during physiological or psychological stress, when to suspect adrenal crisis, emergency management of adrenal crisis, ongoing care and monitoring, and managing glucocorticoid withdrawal to prevent adrenal insufficiency. This was the one that was the most discussion. The endocrinologists weren't keen for this to be involved, but everybody else was. And I think it was a really difficult section to write, as you may gather. But I suspect actually it's a really useful thing to have, because there's some principles that need to be followed, even if the exact detail, you know, there's different ways to skin a cat when we're talking about this, but the principles hopefully will be there. So first section, information, support and decision making. Sorry, the other thing to say is, of all the talks I've ever done, this is the most words, and I'm really sorry about that. I haven't got any pretty pictures to lighten the mood, but it is a very wordy document, obviously, and in my clinical practice we have some flowcharts to describe this, but I wanted to really stick to pretty much to what was said in the guidelines. So apologies if you get a bit word tired by the end. So the first section we thought was important to talk about information, support and decision making. So we talk about shared decision making, giving information on the NHS steroid emergency card and BSE PED card, why somebody may be on glucocorticoids and why they've been prescribed them, having good supply, especially when traveling, some really practical things around free prescriptions, which I suspect often we forget to tell our patients about, when to take extra, when to seek help, call 999, advice on how to administer glucocorticoids in an emergency management situation, and information on patient support groups, and in providing management plans and information to other settings. So we'll think about schools, but also care homes and prisons and places where vulnerable people may be in residential care. So these were some of the principles that we felt were important here. Initial identification and referral. When suspect adrenal insufficiency, this was hard. NICE wanted precision. We know in all the textbooks for adrenal insufficiency, there's a great big long list. So we tried to say what we thought was the most important, and we had to dig our heels a little bit because it does look vague, and we know it can be really vague. We talked about signs, especially increased pigmentation in primary adrenal insufficiency. And if you want to see details, they're obviously all in the guideline. We also thought it was important to use some other things. So people have recently stopped using glucocorticoid by any route, more than 4 weeks if age 16 over and more than 3 weeks if under 16. Yes, I agree, it doesn't make quite sense, 4 and 3 weeks, but this is what the literature said, and we couldn't really deviate where this had been published somewhere. We wanted to say that people having on physiological doses of glucocorticoid who are having episode of physiological stress also may have an episode of adrenal insufficiency or crisis, because they're not doing sick day rules if they've not had all the education. So we thought it important to say that population. And then the other group is when we see adrenal insufficiency, people taking opioids, checkpoint inhibitors, and then drugs that affect the production, metabolism or action of cortisol. So really think about antifungals or antiretrovirals. So practices where there's a large HIV service, for example, may see lots of patients having this scenario. We thought obviously important to check coexisting conditions such as hypothalamic pituitary disease, radiotherapy, and then for pediatric people with, born with ambiguous genitalia and neonates. So some of the things when to suspect for the non-specialist. We talked a little bit about blood testing, so not to test for adrenal insufficiency in people taking oral glucocorticoids at physiological equivalent doses or above. We get lots of referrals with glucose cortisol of 10 who are on dexamethasone. We want people to be aware of taking exogenous glucocorticoids, intramuscular, inhaled or topical, can affect an 8 to 9 a.m. cortisol level, and that our screening test would be an 8 to 9 a.m. cortisol test for adults, and for children under 1, it didn't matter so much, there's no diurnal rhythm. We also again highlighted the fact around intramuscular, intraarticular glucocorticoid can last a long time, and the effect of oral estrogen on CBG. As I said, 8 to 9 a.m. cortisol is the sort of screening test. We talked about physiological doses, which this audience should know, but we've quoted this as hydrocortisone 15 to 25, prednisolone 3 to 5 milligrams, or dexamethasone 0.5 milligrams. This caused some issues around the BNF, but because it's different to BNF dosing, but this is where the committee was really strong consensus that these were reasonable physiological replacement doses. And the biochemists among the crowd would be happy that we have a comment on the cutoffs for use of modern assays and use your local guidelines or local cutoffs as well. So these are the cutoffs that we came up with, and this is also based on what's on the literature, and also the European Endocrine Society's withdrawal document actually has numbers that are the same. So we suggested that below 150 for an 8 to 9 a.m. cortisol, this was high possibility of being adrenal insufficiency, not 100%, and if they're sick, refer on to casualty, and if they're not sick, consider starting glucocorticoid and refer to endocrinology. 150 to 300 is a grey zone. We suggested repeating unless there's a high index of suspicion, and if it remains at this level, refer to endocrinology, may need further testing, may not, and above 300, recognise adrenal insufficiency is really unlikely. Okay, so moving on to routine pharmacological management. This was an area where, again, the committee, we had a lot of discussions, and this is where it differs from the BNF. And we talked about the first choice glucocorticoid, which is hydrocortisone, split into 2 to 4 doses, 15 to 20 milligrams a day. And if people have stopped growing, prednisolone split, total daily dose of a single dose of 3 to 5 milligrams a day. When we look in the literature, actually, it's really difficult to find really strong evidence for this, and this is something that may change with more research, but that's what we suggested. We then talked about modified release preparation. Somebody's on, can somebody mute? We talked about alternative glucocorticoids, and again, we need to be evidence-based here, and the evidence is not strong unless there's a good reason to try modified release hydrocortisone, and they're very expensive, and this is where we have to remember the health economic impact. If something's more expensive, we've got to have good evidence that there is benefit over existing preparations. For primary adrenal insufficiency, we talked about mineralocorticoid, which is fludrocortisone, a bit about dosing here, and thinking people who are young and physically active actually may need bigger doses. Again, this is a little bit outside of it was outside of it was off-label, so we had to qualify this, but great, I'm thankful that we were allowed to include this. And again, we talked about increasing doses for people on enzyme-inducing medications. There is no evidence to support at the current time subcutaneous pump or intramuscular or intravenous administration for daily replacement. And we talked about if someone's persistently hyponatremic, may need additional salt supplements, but here again, definitely would need to be in specialist advice. We talked about emergency management kits, which people here may not be surprised, but actually there's nowhere that tells everybody from an NHS perspective what to do and what is in a kit. So again, this is where we use the committee, and it went out to other people. And also, hopefully with this, GPs currently are not commissioned to supply the kits, but hopefully now we have this document, this will improve care sort of moving forward. So we talked about what to include in what a kit. We talked about glucose gel only for children, and actually you don't need to, the skin doesn't need to be aseptic, so you don't need to use a wipe or anything like that. I'll leave you all to read this. We talked about giving 2 to 3 kits Again, there's a long debate about how many we should give. There's no evidence in this, so this had to be practical. We talked, but giving a kit to people with confirmed primary and secondary adrenal insufficiency. We didn't think that everybody needed an emergency kit with tertiary adrenal insufficiency unless there was a high risk of crisis. There's about 1 million prescriptions for glucocorticoid, and we know that many people don't have an adrenal.
That's your brain.
Can somebody go on mute? We know that not everybody on exogenous steroids gets, for other conditions, gets a crisis. So this was why this advice was given, recommendation was made. Talked about under children, and we also just reminded people to check their expiry dates on drugs, but also the needles and syringes. Management for physiological stress. We talk about, and I know this has caused some queries, but we know that people are on different doses of hydrocortisone. We know that in the pandemic, people having adrenal crisis on just doubling doses. So we have written 40 milligrams recommended, 40 milligrams of oral hydrocortisone in 2 to 4 divided doses, or at least 10 milligrams of prednisolone in 1 to 2 divided doses until the acute illness or physical trauma is resolved. We advise people over 10 milligrams of prednisolone don't need sick day rules, and advise against increased glucocorticoid for long duration. We talked a bit about advice over vomiting. Again, most people here know this, taking it after you vomit and using in emergency injections. And if persistent, if people are that unwell, they need to go to the emergency department. We talked about using parenteral, so either intramuscular or intravenous hydrocortisone if people are in hospital, unable to have prolonged diarrhea, vomiting, and unable to absorb oral medication, and the recommendation around what to do if people are in hospital, which is either giving the continuous infusion and very unwell, so either the continuous infusion or 50 milligrams IM or IV 4 times a day. I don't think any of this will be new to anybody in this audience, and we used other recommendations when we're drawing this up. And again, emergency management for surgery. So again, your 100 milligrams IV or IM on induction, and then either your 200 milligrams and there is an infusion, or 50 milligrams IV or IM. There's no evidence to support any of these are better in terms of clinical outcomes. So it needs to be what's safe in the area of practice that you work. There's a section on pregnancy. There's advice around people being seen by an MDT, telling their healthcare professionals early. And this is the mistake I found. We've tried to be precise around glucocorticoid, and there's a corticosteroid that slipped in here, I found. There's actually separate advice from this guideline, but there's a hyperlink in the guideline for management on for labour and planned emergency section. And it's basically the same as the sort of sick day rules for surgery. So you have your 100 milligrams and then 50 milligrams IM or IV until after the baby's born, with a further shot 6 hours after the baby is born. We talked about people on need to consider this on people who are may have hypo-HPA axis suppression because they may have adrenal insufficiency. I think I've actually talked around this. So this is really what I've just said around giving the 50 or 100 milligrams, and another one 6 hours after the baby is born. The guidelines, this is from the obstetric guideline. They've said don't give supplemental hydrocortisone in intrapartum period to people taking inhaled or topical steroids. I think, again, if someone was on a large dose of topical steroids, that may need extra, but normally people are not on that. I think this is important. Again, there's been deaths for hyperemesis gravidarum, so I picked this out. Can be really difficult to manage. And we felt this was really important, that people should be in hospital if they had adrenal insufficiency and hyperemesis gravidarum. And again, giving the 100 milligrams intramuscularly, go to the emergency department or early pregnancy unit, managing the inpatient rather than outpatient setting. And again, going back to our sick day rule dosing. But I think the key here is people can get really sick, and we know there's been deaths, and this is an inpatient management. It can't be managed as an outpatient for the acute phase. We had a long discussion about what to do when people go home, and when people had to take it orally. I think we following the usual sick day rules is what was written for if people are still having some vomiting, taking medication after vomited, and then again, if it persists, we need to go back to hospital. Management during psychological stress. Again, a lot of discussion. There's very little evidence to support what to do for psychological stress. And we just defined this in the end of the document. There's our terms. We've defined our terms. We defined, for the purpose of this, psychological stress as periods of sudden, intense psychological and emotional stress, for example, bereavement, exams, significant life events such as getting married or divorced. I can vouch that those are quite stressful. But the principle here was, it's not every single little everyday stress, because there's a risk of over-replacement, and just really, again, the evidence isn't supporting that type of stress as needing extra updosing. And we've suggested this, we consider sick day dosing for 1 to 2 days during psychological stress. So one thing that I didn't say is around the terminology. In a NICE guideline, the terminology is everything. When it's consider, it means it's a weak recommendation. And so we use consider here because it is weak. And then if it's offer, that's actually a strong recommendation. But if you think it's life or death, you can say give. So the consider, the offer, and the give are really important words. So anyway, we talked about, being careful around when to think about giving extra for psychological stress and do it for the shortest period of time. We felt it was really important to talk about sick day dosing for severe mental health crisis, so either psychosis or severe mania. And if someone's in a mental health institution, it'd be really important to have extra. And that may need to be 100 milligrams IM, and that's why that's included. We talked about trying to reduce our psychological stress, which I think is probably true for all of us, but particularly patients may be fearful with adrenal insufficiency, and consider referring and self-referring to NHS Talking Therapies Mental Health Services. So we've signposted to that. Section on when to suspect adrenal crisis. So here again, there's a long list, isn't there, of when to suspect, and this was the list that we felt was the most specific. And so hypotension, hyperpigmentation for primary, and we're trying to, really stressing that. Hyponatremia is quite, it's not a diagnostic, but there was some evidence. So, and if you want to look at the evidence showing that it's a higher, can be used in an algorithm. And hypoglycemia, particularly in children. And if someone's, very hypotensive and not responding to treatments, that should be a red flag as well. Some of the milder symptoms we've written as lethargy, pallor, clamminess, feeling cold, feverish, confusion, or altered mental states and weakness. And this is where the patient partners were really helpful, sort of describing how people feel when they've got an adrenal crisis. And every person had a sort of different thing that they knew when they were getting a crisis. The emergency management of adrenal crisis is basically, I'm sure everybody here is aware, giving either IV or intramuscular hydrocortisone. If outside of the hospital, can be IM. There's no risk of overdose. We felt that was important. And you can see we use give here. So this is because it's really important, isn't it? With a crisis, it's not a consider or an offer or anything else. It's a give. And there's no risk of overdose from hydrocortisone. This is to protect people who may be different prescribing rules, or people outside the hospital, to sort of give confidence. If you really think it's a crisis, give the hydrocortisone and we can unpack it later. We'd advise people to go to hospital in an ambulance without needing a referral, or go immediately under their own steam. And then talk about giving fluid, and need to be in an area where there's frequent monitoring. We felt that we couldn't be specific about where to be because every hospital is a little bit different, but the principle, isn't it, about frequent observations and frequent reviews. So again, we advise to carry on giving it hydrocortisone either continuously or 4 times a day, continue fluid, and then when someone's better, reducing to oral at sick day rules. Try and identify and treat the underlying cause of an adrenal crisis, and if not known to endocrinology, need to be referred to the specialist endocrine team for ongoing clinical advice. We felt it was really important that everybody with a crisis in the hospital should be referred to endocrinology or equivalent. Sorry. Oh, hang on, that's not right. There you go. Ongoing care monitoring. So this is difficult. Again, there's very little evidence to guide us here, but we felt it was really important because people would look at this. Obviously, it's really important. People are going to look at this document and may decide how healthcare can be offered. We felt it was really important to look at the individual and use shared decision-making model. We felt that it was important to have more frequent reviews around time of diagnosis, during periods of rapidly changing clinical needs, during periods of rapid growth for children, babies and people during puberty, during transition of care to adult services to make sure people have safely landed with adult team. If there's concerns about medicine's adherence, that may not need to be with a doctor. We've not specified who somebody needs to see. And if there's concerns about the person, the carer's family being able to safely manage the condition, and people may need frequent reviews or check-ins for vulnerable people. There were some groups who felt needed, who you could offer less frequent reviews. So adults on exogenous glucocorticoids, adults who are confident with self-management, and adults with stable clinical need. There's very little evidence to actually say everyone needs a 12-monthly review. Everyone needs a check-in, but we can be practical. Different healthcare providers can offer this. We have different ways now of delivering healthcare. Some of the things I thought was important was to ask about how somebody is, psychological well-being, and ability to carry out day-to-day activities, and understanding how well someone understands their condition and how confident about managing it, medication adherence, how frequently they're using additional glucocorticoids, so sick day rules or emergency injections, understanding of sick day rules and education. I have a little, what's it called in my clinic note, a little smart phrase that reminds me to talk about this with every patient. And it's quite, the answers you might get may not always be what you're expecting. And something actually which I need to add to my own little reminder is the frequency of adrenal crises, hospital admissions, infections. If someone's going to hospital a lot, is there a reason for this? Is this an adherence issue? Is there something else going on? And we talked about the importance to advise someone adjusting glucocorticoid, like with travel, if somebody's working nights, if endurance exercise and shift working. We put some signs and symptoms of glucocorticoid over and under replacement, just things to look for. So things like for under replacement, weight loss, decreased appetite, fatigue that's significantly affecting abilities to daily living. I think that's really difficult, isn't it, in real life, but felt it was important to mention this. And over replacement, weight gain, increased appetite, diabetes, hypertension, the usual signs and symptoms of steroid excess. I think when someone gets to that, it's going to be quite significant steroid excess, but it's really important that we need to be thinking about this. In terms of what to offer as part of review, again, here we're evidence-based, and talked about blood pressure, lining, standing, electrolytes, HbA1c, bone density, very little evidence to support this, and the recommendation was once within at least 5 years, and after that, if it was normal, there's no need to repeat it, unless clinical situation changes clearly, and lipid profile for adults. There's no evidence to support cortisol day series. Check hydrocortisone dosing. Remember, this is a guideline, not a tramline. So some people, you may want to do that, but it's not part of routine clinical monitoring. And for primary adrenal insufficiency, it's important to monitor signs and symptoms of mineralocorticoid under or over replacement. So lightheadedness and salt craving, and swollen ankles or high blood pressure. And think about measuring a renin when you wanted to, considering adjusting a fludrocortisone dose. You'll see we don't have antibodies there for diabetes because there's no evidence that's going to change an outcome. And actually talking about risks for other autoimmune conditions may be more useful. There's a small section both on transition from adults to children's services. Really, it's just reminding people how important this is. And there's a whole separate NICE guideline there if people are interested. And people receiving end-of-life care, just additional considerations. There's a lot of shared decision-making here anyway, and palliative care are fantastic at discussing these things, but we felt there was a principle to use once-daily formulations and routes of administration, such as subcutaneous or intramuscularly, and consider this. And a patient may decide that they actually want to stop their glucocorticoid replacement when they're actively dying. And so it's really important to kind of think about that. And again, there's NICE guideline on, things to think about when we're thinking about end-of-life care. So this is the last section. So, and this was really difficult to write and be interesting and reflect on the feedback, and in the questions. So we talked about the principle, and this is really for the non-endocrinologist. And reducing glucocorticoids, this concept of physiological equivalent dose, which I think is new to a lot of people. And so in our defining terms, we've quoted this. And so getting down rapidly, and this has to be done by the team that's looking after the patient, because if you've got an underlying condition, endocrinology can't tell somebody with, severe COPD or a bowel condition what to do with the steroids. It needs to be that clinical team's decision around reducing the dose and when the time comes to stop. So we talked about when they get to that dose, reducing down to physiological dose, every other day for 2 weeks, twice a week for 2 weeks, and then stopping. So a gradual wean off. And we know that we don't get asked to see most people with adrenal insufficiency, on exogenous glucocorticoids for other conditions. So we felt this was pragmatic advice. For people taking glucocorticoids longer than 12 weeks, they may need a slower dose tapering. And I don't know if Karim is on the call. We shared the picture, which the example from Imperial, which is just one way of doing this to kind of, so people could see visually an example of reducing slowly down from 3 milligrams of prednisolone a day. Other examples I'm sure are out there, but this is just one that was available. We shared this. Just some other pointers that we said is changing from, so this is really thinking about oncology population, because they're the people that use dexamethasone the most, from switching to dexamethasone to prednisolone to manage dose tapering below physiological dose in people age 16 and above. There's no need to routinely change from prednisolone to hydrocortisone in people over 16 to wean. That's done in sometimes, and it's a time and there's a time in doing that, and you can just slowly reduce the prednisolone. And we talked about, sorry, looks like I've missed a bullet point there. We talked about steroid withdrawal syndrome being, expect temporary symptoms, including fatigue, reduction in appetite and low mood. That's very similar to actually those of adrenal insufficiency, and to be aware to expect that. And that isn't necessarily a sign of adrenal insufficiency. And to advise people what symptoms to expect. Oops, perfect. That's me to give time for questions and discussion. So I think I've got 2 more slides left, I think. So when and how to test for adrenal insufficiency and withdrawal. So we felt that if people were doing well, had got no symptoms, there was no need to do any testing. If people did develop signs and symptoms when they're on a below physiological dose, we advised an 8 to 9 AM cortisol to assess. And we said pause prednisone 24 hours, hydrocortisone 12 hours, or dexamethasone at least 72 hours before the test, and then restart at the physiological equivalent dose if concerned whilst waiting for the result. So we're quite specific here because, again, we get a lot of referrals when people are stopping the dex, but it's like the day after, not 3 days after. And then again, we use the same numbers, which is the same as the European Journal paper around what to do. So again, below 150 to be safe is to restart the glucocorticoids. 150 to 300 is a grey area, may need a snack and may need a repeat, and above 300 the patient is fine. Lovely. Great. So they are the sort of key pointers from the guideline. There's also at the end, there is a definition of terms. There's I've forgotten now what it's called, where we talk about why we've come to the recommendation. So that's a good place to also look to see if you're not quite understanding why. And then I'd encourage anyone, if you're interested, to go to the NICE guideline itself, and at the end, if you go to the website, and maybe we can put it in the chat, I'll put it in the chat whilst I'm answering questions, because it's got all the evidence reviews there. There's some great evidence that's reported there as well, so you can see where our evidence and our cost-effective analysis was done. So brilliant. So I'm now going to open out to questions. If you keep your mics off, turn cameras on if you wish. You don't have to. Put your hand up, and I will take the hands in turn, and then between us, Rachel and I will look at the chat, and I'll try and not miss anybody out. Oh, I've just got to write down just in case you ask me something tricky and I've got to think about it hard. I can see Duncan Flowers is going to put that in the chat. So I'm going to take Duncan first. Hello, Duncan. Thank you for joining. Yes, hi. Hey, yeah. So your question, in case anyone can't see, is emergency kit is very specific. So NICE, as I mentioned, you have to be concise and precise. We can't do anything we can't be anything had to be willy. It's a guideline, not a tramline. So if you feel comfortable with 1 syringe, that's fine. I don't think this is telling in this context. I think the worry is if people, they fumble and drop it, but I think one is fine. I don't think anyone's going to say you have to do differently if it works. Sericar's not available. I didn't know that. There's an NHS BSA is the people that provide them. Are you saying, maybe we can catch up offline, are you saying that NHS BSA aren't supplying them at the moment?
When I looked online, the link was broken, and there's no way I could find around it. But that just might be me. I'll need to look harder, maybe.
I hadn't heard, and Julie Windsor, my NHSE rep, and they email me. I have great power telling how many can be printed. It's real fun. So 2,000 today, 5,000, sell, bye. But anyway, if it's still a problem, let me know and I can bump it up the chain, but I wasn't aware of that, so thank you.
Thanks.
All right, someone's got a hand up. Let me have a look. Who's got a hand up? Emmanuel Guest. Emmanuel, what's your question? Hello, Emmanuel Guest.
Can you hear me, Helen?
I can.
Thanks for the work you've done on this as well, and for presenting this really nicely today. I've got 3 questions, actually. The first question is around sick day rules during intercurrent illness. So how long do you keep following the sick day rules, or doubling the dose, for example, during intercurrent illness? So you've got someone sometimes that they've been in hospital for weeks and weeks, and you're thinking, at what point do you actually just decide to go back to your normal dose, or do you just wait till discharge? The next question I had was around, if someone was on equivalent to 15 milligrams of prednisolone, do you double dose, or do you just keep on the 15 milligrams? And the third question was around, has there been any discussions around kind of merging the blue steroid treatment cards with the emergency steroid cards? Because most times you get times when you're saying, do you give both? Do you give one?
It's a really good question. Yeah. So that's a really good question, which I will sit on I won't sit on the fence. I'll tell you what's happening. So thank you. So sick day rules. So it can be tricky. If normal, I wouldn't say discharge is a point to end doing sick day rules. It's a patient by patient, and if it's so there's a really nice paper that Alessandro Preti and team did showing cortisol response, and we probably overtreat for sick day rules a little bit. And so if someone's got a fever, when the fever settles, usually as it starts settling, the inflammation response, which, the cytokine drive, that's dying down. So when that happens and people start improving, generally what I do is taper down when somebody either becomes apyrexial or the acute episode is over. And I wouldn't really count hospital discharge as somebody being better, but again, it depends a little bit on individual cases. So I think it's not, even if someone's on, some people say when antibiotics, that's not what personally I do. It's not in the guidelines, so I don't know if I'm allowed to talk about this because it's a guideline day. But somebody could be on antibiotics for 3 months, but actually only unwell for the first week. So it's really a clinical decision when you think that patient is getting better, and then wean down back to their normal dosing. In terms of prednisolone 15 milligrams, this is more than physiological. So we've said 10 milligrams in the guideline. There's no need to do sick day doses for 10 milligrams, but people may want to split it to 5 twice a day or keep it on the 10. In terms of the blue and red cards, that's not part of the NICE guideline. One thing I've learned of all this work, there's bits that NHS England do, then there's NICE, and NHS, and actually nobody owns nobody knows who owns the blue steroid card. So, and the other thing is around the cards that they have to be, there's the devolved nations, so Wales, Scotland, Northern Ireland, as well as England. So NHS England, even though we've got the red card, Wales and Scotland have got their own. I can't remember where Northern Ireland is now, in terms of card. So there's been basically a lot of discussion at NHSE level, and it was with the NHSE CMO, which was Chris Whitty, I don't know if it still is, because it's got all sorts of implications around the devolved nations. It's not a real simple, straightforward decision. So I agree, it's tricky. You don't know what to give to who. I don't give the blue cards, I only give the red cards. And I'm afraid it won't be quickly resolved, but it is on the list of things to try and resolve. I hope that answers that question. Any other questions or comments? Oh, I thought everyone would be. I can see someone. Alison. Hi, Alison.
Hi there. Thank you, Helen. Thank you. Just about the red and blue cards in Aberdeen, we've had quite a big discussion about this recently with the pharmacists. So pharmacy give out the blue cards whenever there's a steroid prescription, so a glucocorticoid prescription, and then we still give the red cards as well. So we say the clinician should be giving the red cards,
Yeah.
not the pharmacists, unless they are well aware that they're within risk of AI, obviously. So we're sort of using both at the moment still. So
Yeah, and I think, I mean, one thing around this is, and this is why, is the guideline isn't actually around implementation. And so some of the things may look really great when they're written in paper, but actually in the real world implementing it is really difficult. And it also, and I think it's quite right, the guideline doesn't say about implement, because different areas have got different challenges. And so what happens, so in our hospital, we can, a little bit similar, what we do, we have them in, obviously, in our outpatients and give them out. And we've just only just got to the point where we can order it electronically, so pharmacists can give it out. So I think we've probably got a similar system, and iteratively that may change down the line. But again, I think the point, isn't it, about implementation, it's how your organisation is working. You know, in primary care it might be totally different. You know, it's not for us to tell primary care how to do it. But thanks for sharing that.
thank you.
Any other questions or comments? Or, well, nobody said it's terrible, so that's a win, isn't it? Anything people would challenge if they were in my shoes next time round? I'm not hearing any strong challenge. Hopefully we addressed a lot of the things during the consultation period. I know it's not perfect. James, you're going to challenge me.
No, I'm just going to make a comment, really. I take the point that these are guidelines, not tramlines, and they're designed to educate and help and inspire and encourage good practice. But there's a background pressure that when people don't know and they want to determine whether your practice has been good or not, they apply an external guideline to an individual person. Yeah. And so people will say, well, why aren't I getting this number of needles or whatever level of care you're defining in there, and give us a hard time because of it? I'm not disagreeing with you at all. I just think one of the problems with guidelines is that they become a stick with which we are beaten, rather than a way to inspire people. Just a comment.
I think, and I agree, and that's why every comment in every recommendation there is really carefully discussed. And where there isn't evidence, you know, it was, you know, the consensus of the committee, of this committee, was to, because if you drop it and it's an emergency, personally, I think it's not unreasonable to ask for 2, but if someone's doing 1 until it's challenged, I think that's also, you know, 1's better than none, isn't it? You know, if you're getting your kit, that's good. So I hear what you're saying, but I think, you know, it's oh, I can't remember what I was going to say then. Lost my train of thought. Couldn't have been important. But yeah, I hear what you're saying. Somebody else put something in the chat. So it's a good question. Somebody's put in the chat about waking salivary cortisol and cortisone when people have a falsely low cortisol and low albumin. So there's no evidence to support that. So there may be evidence in the future. And at the moment, there wasn't strong enough evidence to use salivary as a diagnostic. I know there's lots of really fantastic work, which I presented in BS last year on salivary cortisol and cortisone. So it may be, again, whoever writes this guideline next will be using salivary, but at the moment evidence isn't supporting that. So the short answer is no, not yet. But a great question. And I think, you know, just again, a comment of what I really learned from this is we have to be so careful in guidelines. I see a lot of guidelines that are based on very poor evidence, and then people are bringing that into clinical practice, and actually there isn't any outcome data, there's no health economic analysis. You know, so we have to be so careful of the implications. We've talked about emergency packs, but actually bringing something in where there's no evidence really to support it, or strong high quality evidence, is also equally dangerous. Okay, so anybody got any last burning comments or questions? Not seeing anything. No last minute.
That's a quick one, Helen.
Yeah.
So in my trust at the moment, I've just been asked to kind of draft a new, or kind of edit the current guideline we've got based on this new recommendation as well. Would you recommend having the PEDS guidelines separate from the adult one, or would you just do both in one document?
So it's a good, I think, again, it depends how your trust works. The ones we have at UCLH, our trust document is adult, and pediatrics got a separate one. But I think, I mean, I think you could argue it both ways. I think it's probably, it's always difficult, isn't it, around the sort of age of 16 to 25, because, but I would, I probably suggest splitting them, but, you know, that's just because that's the way I've done it in our hospital, the way we've done it, because we don't look after children. And, you know, if anyone asks me something around children, you know, I can think of the principles, but I'm not the best person to ask. So that's how we do it. But great, well done. Thank you for updating your trust guidelines. Okay, so this will be the last question then. If someone's treated with adrenal crisis on 50 QDS, you drop their usual dose. I think, Cinderella, I think the question is, do you go straight to the usual dose or do you wean? Is that right? So what we do is gradually, and I think it says it in the guideline, is you use the 6-day rule oral dosing, and then you go to the, so give them a bit of time. And again, it depends how well the patient is. You know, you give an increased oral dose, and then as they get better, you can then reduce that back to the normal dose. And the timing of that depends on each individual patient. Great. Okay, well, thank you so much for joining. The slides will be shared, but not straight away, because I forgot to tell NICE I was doing this, and I have to tell them before I do any sharing of the information. So if you never see me working again, it's because I'm being struck off for sharing it too soon, but it will be shared on the SFE website. Thank you for everyone who's giving out the cards. Any feedback around this, if you can't order the steroid emergency card, please let me know. Anybody thinks there's something that should go on the SFE Adrenal Crisis webpage, the team are fantastic at updating that. So we can put, if anyone's got any great resources, you know, the team are more than happy to make that really useful for all of us. And I shall let you all go and enjoy your Wednesday night. So thank you very much, all of you, and keep well.
Thank you.
Thanks, Ellen. See you soon.
Thank you. Cheers.
Bye.
See you all.